This is Andy Schumann for MedGizmos with another interview. I have the honor and privilege of interviewing David Kraus, who is CEO and developer of Outcome Referrals, as well as his chief of staff, who is Charity McBee. So David, I'm a pediatrician and you're a child psychologist. We've both been doing what we're doing for many decades now. So I'm very curious about Outcome Referrals. So give me the backstory. So where did you start as a clinical child psychologist?
Yeah, I right out of grad school, I started working at UMass Medical School. My day job was to run the inpatient unit for the most disturbed kids in Massachusetts. I was also, as an assistant professor of child psychiatry, helping to train new both intern and resident psychiatrists on what's now known as complex trauma.
Mm-hmm.
And it was around that time that the Clintons were first talking about national healthcare reform. And one of the things that Hillary said that resonated with me is that anyone in healthcare, didn't matter if you were an ER doc or a psychologist like myself, needed to document that on average your patients improved from the care you delivered. And my head said that makes sense. And my heart said that the health plans that they're going to try to monitor what I do every day are going to get it wrong.
Yep. Yeah, you're preaching to the choir here. So how did you get the idea for Outcome Referrals, and tell me how it evolved and eventually what it was designed to do?
Sure. Well, we instantly started thinking about how do we properly measure the quality of the care that we deliver. And I had just left UMass and was working in a group private practice in the Framingham, Massachusetts area. And in researching what the state of the art was in measuring the quality of behavioral health care, I got quite discouraged about what the feds were pushing, like the SF-36. And the closest it comes to asking face valid questions for behavioral health is, do you feel down and blue? Do you feel full of pep? And the rest of the questions are asking things about whether you have trouble walking up a flight of stairs or running a vacuum cleaner. And I don't want to discount those kind of quality of life or activities of daily living kind of concepts, but I can't hand a questionnaire like that to a patient and say, what I think is the one sentence we need to be able to say, which is, by filling this out, it'll help me understand what you want to work on.
Okay, let me interject and ask, because I have a wide audience. Can you tell us what that is? Was that a House bill in Massachusetts requiring mental health screening, or you're referring to a mental health questionnaire specifically?
Well, what I'm referring to is that I was trying to get ahead of the Joneses, and if the Clintons had actually succeeded in what Hillary was suggesting that we do, is that we all need to measure the quality of our work. And so I started researching what is the best state-of-the-art tool out there, and got discouraged and basically went back and developed something from scratch.
Okay. As a pediatrician, I use a number of questionnaires to assist in diagnosis: PHQs, GADs, CRAFs, and so forth. So those are useful for us clinically in making a diagnosis and monitoring symptom improvement during the course of medication management. So, and that's something that clinical psychologists use as well, and you have a whole repertoire of screens that you use. So what you're doing is different, because you're using or have developed a questionnaire to manage your improvement over time and see if there's benefit from what you're doing. Is that correct?
Yes, I would say that the differences between what we've developed and for example, something like the PHQ-9 and the GAD-7 and other things, is that ours is more sensitive to change. It's more predictive. It's risk adjusted. So we're taking into account how severe the client is when they start treatment. And it's not filled with some of the kind of problems that are built into, like, my pet peeve about the PHQ-9 is the last question. where
Okay.
you're merging two extremely important things like hurting yourself and suicidality that doesn't make sense to me. And I don't know clinically how to handle somebody that's endorsed that question. So for example, somebody that has decided to commit suicide
Right.
is going to find usually some sense of relief that they've made a decision. And they may endorse that last question on the PHQ-9 with more health, what looks like more health when it's really that they've made a decision and we need to be extra worried. So we went back to the drawing board, and one of the other benefits is that in one questionnaire that's 48 questions for a kid or an adolescent to complete, we're measuring 12 different domains like ADHD and depression and psychosis and substance abuse. So you don't have to be throwing multiple questionnaires at folks.
Yeah.
And then what we just published in JAMA was the first randomized clinical trial of a referral process in healthcare. And we showed that we were able to double the outcomes for the Cleveland Clinic's primary referral pathway out of family medicine into the community by using that data to figure out who's the best scientifically matched therapist in the community to treat that individual.
Okay, that's great. Yeah, on your website, you've got a lot of publications. And so currently in its present form, you've got what, a 48 question questionnaire. Is that correct?
So it depends on the age version. The kid and adolescent version is about 48, the adult version is 58. So
Okay.
it takes about 5 to 7 minutes to complete.
Okay. And are we talking completing it by way of an online portal and it's scored automatically with results presented?
Yes.
Okay. And is that much like Me Health or Chattis? I imagine you're familiar with those
Yes.
entities as well. Okay.
Yeah.
That's great. So once a pediatric patient fills out that form and it's scored, so what is then recommended? Do you do further testing, or if it's is it recommended that you do GADs and PHQ-9s or 12s or some other testing?
Folks can follow on with more specific testing if they want to. There's no need to do a PHQ-9 or something that's around depression. We're measuring depression as accurately or more accurately than the PHQ-9.
Okay, so your outcome referral questionnaire is then diagnostic and could be used diagnostically for someone like myself to consider prescribing appropriate medications.
Correct. And then using that same scale to monitor the course of treatment, find out if the client, we give alerts if the client's off track and not responding well.
Okay, just out of curiosity, because a good 25% of my patient load is ADHD patients with comorbidities.
Yep.
Does it do any screening for ADHD? And will it diagnose it, or do I have to do Vanderbilt's or Connor scales?
Yeah, for ADHD, I would follow up with a more detailed questionnaire like the Connors.
Okay, that sounds good. So what is the name of your questionnaire? Is it called Outcome Referrals, or what's the questionnaire itself?
It's called the Treatment Outcome Package, or TOP.
TOP. Okay.
Yep.
And so Charity tells me you've been doing this for a long time, and TOP's been around for a long time. I saw a paper you published in 2005. Yes. Showing how well it works. So it's and I think that original paper had a much longer questionnaire, was over 90 questions.
This is the fourth iteration of the scale. The first version actually had over 250 items, and through large scale factor analytic work, we've boiled it down to the 58 questions that are really sensitive to change and very quickly get at these 12 important dimensions of health and quality of life.
Okay. So you have a online portal, much like Chattis does, Me Health, and I'm sure there are others, but you've been around for some time. And how long have you been available?
30 years.
30 years, and I've been unaware of you for that long a period of time. There must be a reason for that. Is it very expensive? Is it something that's covered by insurance?
Yeah, insurance, there are CPT codes that cover it, so it can actually be a revenue generator for a practicing physician. And the reason why we haven't been out shouting from the rooftops is that we've been working on finding this needle in the haystack of how do we use this data to truly drive better quality outcomes. And with the study that we just have published in JAMA Psychiatry, we feel like we are fully ready to have this be something widely adopted.
And again, the study that was just published indicated what, David?
So what we did is we went to the Cleveland Clinic and we went, John Hickner's was at the time the head of family medicine there. He introduced us to their primary referral pathway out into the community that was called psychological and behavioral consultants. And so for several years, they were using our tool to measure the quality of the behavioral health care delivered by their 250 or so therapists. And then when PCORI funded our randomized clinical trial, we used the data that we had collected and risk adjusted. A patient starts treatment, they take the top, and we use that data to find a short list for them of those 250 therapists that have the best chance of helping that patient get the outcomes that they deserve. And we compare that randomly in a double-blind trial with what they thought was the best method of matching, which was what we call self-perceived strengths. Therapists would say, I'm really good at substance abuse, I'm really good at depression, I'm really good at ADHD, and we matched. So if they were in the control group, they got matched based on the way they had been doing it for years, which is the client calls in, says, I have ADHD, gets matched with a therapist that's raised their hand and said, I'm great at that. And we doubled those outcomes without changing anything that the therapist does.
Okay. How did you determine if a therapist is good or not?
So if you look at our 2016 paper in the Journal of Consulting and Clinical Psychology, we went through an elaborate analysis of how many outcomes does it take to find out what somebody's good at, with enough specificity to predict the future. And we found that as little as 10 clients are needed for each therapist to find out what their strengths are once we risk adjust the data.
Interesting. You should develop a similar tool for physicians. You know, that's an interesting concept.
So on the behavioral health side, what we actually do, one of our latest publications is in the Journal of Family Medicine. Is that what it's called? What's John Hickner's the editor of it? JFP, Journal of Family Practice. And we believe that the exact same process can help physicians and pediatricians figure out what clients they're really good at treating themselves in-house and what ones they should refer out into the community.
Yeah, very good. So I'm curious. I'm going to ask a lot of questions and also use the opportunity to vent for a bit. But before I do so, what's the pricing model for this? Because sometimes that prevents practice or a provider from using a particular tool. Because I know there are prices associated with Chattis and MeHealth and et cetera.
Yeah. So it depends on who you're asking the user is. So for a consumer that's looking for a good referral, to go on to matchtherapist.com and take the top and look for a referral, it's free.
Okay.
If they want to store their data, if they want to come back tomorrow and continue their search and store that top information, it's $2 a month.
Okay.
So
Yeah, what about a clinician like myself? Now, you're saying that I can use this as a screening tool instead of CRAFT or GAD or
Yep,
PHQ, and I
yep.
wanted to use it regularly with patients. We screen with CRAFT beginning at age 12.
Mhm. So for a therapist like myself, it costs about $15 a month for unlimited use.
Yeah,
And for a primary care physician or that has a higher caseload, it's $48 a month.
a month. So that's incredibly affordable.
Yes, we want to make sure that price is not the reason for um, not using the system.
Okay, so I can use it and for diagnostic purposes and for monitoring patients. Now, part of the difficulty is monitoring improvement because sometimes clients, patients are not computer savvy. We have to get in touch with teachers to see how they're doing in school regarding ADHD. And a lot of the measures are somewhat subjective. So, and at some point, maybe you can demonstrate the platform, for us online, but is it easy to use? I find Chattis a little bit awkward to navigate. Me Health is pretty good, but part of the success of Eddie Portal is how easy it is to use with as few as
Yep.
quick as
A- a-
necessary.
Absolutely. So for example, our system is used for the entire state of Iowa, the kids that are in child welfare and juvenile justice.
Mhm.
And they send out rating invitations to everyone in that child's life so that they can get a good 360 picture of how that kid's doing.
Mhm.
The caseworker, the foster parent, the biological parent. And in many of those cases, you're dealing with people that are not computer savvy. So it can be done on a handheld. It can even be printed and taken as a paper and pencil tool and faxed to us, and we process it for them. So there are many ways that the data can be collected. The invitation that's sent out by either text message or email
Mhm.
simply has a link that the rater, whether it's the kid themselves or the teacher, clicks on, answers the questions and hits submit. They don't have to log in. They don't have to go find the tool that you asked
Okay.
them to complete. It's sent to them prepackaged just for them for rating that specific
That
child.
that sounds great. So here's my dilemma, particularly during the pandemic, things have gotten worse. So there is a national mental health crisis in our pediatric community that's been identified by the Academy of Pediatrics. It's made worse by the pandemic. I treat so many kids with medications because they cannot locate and get care by therapists. And those that have Medicaid are at a particular disadvantage because Medicaid in many states pays so poorly that not many therapists take them. So it's nice to have a product that can direct people to the best therapist, but it's another matter to get them therapy. So
Yes,
have you confronted that issue in any
yes.
way?
We have tried to tackle both the quality and the access problems. So on the
Okay.
access side, there are two things. One is that in the long run, good referrals take less time to get to a good outcome. And so
Mhm.
there will be more availability as people are being referred to higher quality care. That takes too long to have an immediate impact
Mhm.
for the kids that you're trying to refer. So we've developed what we call a fast pass application where the consumer, the kid, the parent is completing basically this one-page sheet that they can send to therapists that say right now that they have a waiting list, they're full, they can't take anybody right now. I
Mhm.
think the average wait time is 3 to 6 months and growing. In some places, I believe there was a Washington Post article 3 days ago that said they think the wait time is up to a year now.
Right.
But with that application, our research shows that you convince a therapist that you are really motivated, you're a good match for them, and there's no reason that they should just take the next person on their waiting list, because the data shows that 60% of behavioral healthcare delivered by folks like myself
Mhm.
is ineffective or harmful.
Hmm.
In the
Okay.
research that we delivered, by delivering good matched referrals, you dramatically reduce those ineffective and
Okay.
harmful.
Repeat that number for me again. What's the percentage?
60% of patients receiving behavioral health care in the United States find no meaningful benefit, ineffective or harmful care.
Okay. So what has been the response been to this fast pass? Has it been around a long time? Because
It is not. It is going into QA this Friday and released in a couple of weeks. So it's a brand new process that's about to hit the market.
okay. So, but you're optimistic that you can convince therapists to prioritize some patients.
Yes,
Okay.
there's no reason I, as a clinician, if my waiting list is full of people that I have no idea if I'm going to be ineffective or harmful with, and
Okay.
the random chances are that I will be,
Mhm.
and we have data that shows that this is a high quality referral, and by the application itself, when you look at it, suggests that the client is highly motivated, has done their homework. We believe that that will increase the chances that the person will be at least towards the top of the waiting list instead of added to the bottom.
Okay. What about the Medicaid issue? And so they pay 30 cents on the dollar, sometimes better in some states, depending on the state, but that's a big obstacle to mental health services.
Absolutely. And so it takes a dedicated therapist that's accepting that insurance. And so you filter the data based on who's taking various types of insurance. I don't know if it's a good thing or a bad thing, but Beacon, that's the largest provider of Medicaid behavioral health services in the country, has just accepted some of the telehealth platforms like BetterHelp and Talkspace as therapy platforms. I'm not sure that there's any good data that shows that those therapists that are being paid $19 an hour are
Right.
delivering good care.
Wow. Okay. Because when I talk to patients about those services, they don't take insurance and it costs the patient about $100 per week.
Right.
And most of them don't have it.
But for Medicaid, it's about to change, it appears.
Why is that? Is there going to be some federal legislation that you're aware of? Or does
I
it have
don't
to
know.
happen at the
I just
community
know
level?
that Beacon, I don't know if Beacon is delivering services in your neck of the woods, but they do here for Medicaid.
Yeah, I'm not familiar with them. We have a lot of obstacles here. So
Yeah.
David, I'd like to at some point have you or Charity demonstrate the portal for me in another interview. So I'm going to wrap this up. I don't want you both to leave because I want to talk offline about a few things. So I'm going to officially thank you for what is a very stimulating conversation, and one that makes me extremely hopeful that we can potentially improve the mental health services for patients who are much in need. So thank you, David, and I'm going to hit the stop recording
For your
button.
time.